Hello, and thank you for joining us for this Neurology Live Peer Exchange titled Advances in Treatment of Alzheimer's Disease. Alzheimer's disease is an irreversible, progressive brain disorder that slowly destroys memory, thinking skills, and eventually the ability to carry out the simplest tasks. Symptoms of Alzheimer's disease for most people first appear in their mid-60s. There is currently no cure for Alzheimer's, but there are drugs in development that may be promising. In this Neurology Live Peer Exchange discussion, I'm joined by a panel of my colleagues, all experts in the field of Alzheimer's disease. Together, we're going to discuss the advances in diagnosis. We'll review the latest clinical trials and provide practical perspective on how recent data apply to your clinical practice. I'm Jeffrey Cummings, founding director of the Cleveland Clinic Lou Ruvo Center for Brain Health in Las Vegas, Nevada, and research professor, University of Nevada, Las Vegas. Participating today in our distinguished panel are Dr. Alireza Atri, Director of Banner Sun Health Research Institute in Sun City, Arizona, Dr. Richard Isaacson, Director of the Alzheimer's Prevention Clinic at Weill Cornell Medicine in New York, New York, Dr. Elaine Peskin, Friends of Alzheimer's Research, Professor of Psychiatry at the University of Washington School of Medicine in Seattle, Washington, and Dr. Marwan Sabbagh, Director of the Cleveland Clinic Lou Ruvo Center for Brain Health in Las Vegas, Nevada. Thank you so much for joining us. Let's begin. So Richard, I'd like to start with you with our first question. What's the difference between age-associated memory impairment and Alzheimer's disease?
So Alzheimer's disease is a progressive neurological disorder. It's a brain disease. It's a neuropsychiatric disease that involves progressive loss of short-term memory. But it also has other aspects, including changes in sleep, changes in behavior, problems doing complex tasks. And it's a progressive disorder, and currently we have no cure. Age-related memory impairment, or age-related cognitive decline, also is sometimes referred to as cognitive aging. And cognitive aging are somewhat of the normal or expected changes that happen when someone ages. For example, a word may be on the tip of your tongue, but you may remember it later. Also, it may take you longer to learn something or longer to retrieve something, but those are parts of the normal aging process, and it's not pathological in the sense of a neurodegenerative dementia like Alzheimer's disease.
Very good. And does one lead into the other? Does age-associated memory impairment then become Alzheimer's disease, or they're really on distinct trajectories?
That's a great question. I wish I totally understood the answer to that question. In our program, we try to study both. Cognitive changes and cognitive dysfunction due to pathological aging, like Alzheimer's disease, versus non-pathological aging, different cognitive measures change differently depending on the two constructs. So, does one lead to another? Does one make you more predisposed to the other? The jury's a little bit out on this, and it's a little bit confusing. I think there are some aspects of the pathophysiology that are interrelated, whether it's vascular comorbidities, metabolic changes, other things. I think there's a relation, but I think they're distinct.
And
Can I add to that,
yes,
Jeff?
Please, Marwan.
So I was going to say, Richard is right, but we're now recognizing that people who have the age-related cognitive decline, particularly people who complain about their memory, subjective cognitive impairment, oftentimes are predicting changes that could lead to a progressive condition later in the future.
Mm-hmm. So it's a risk factor, maybe.
When somebody's complaining about it. We used to say that
determinant.
Correct. We used to say that we're the worried well. Now we're saying that maybe there's something to pay attention to.
And I would add to that, I agree that nowadays we understand the pathophysiology of these diseases. They're oftentimes proteins that are misfolded, and they start occurring sometimes 15 to 20 years before individuals show symptoms. So there's always this balance between having the disease or these toxic proteins and how much vulnerability or resilience you may have to ward these things off.
Mm-hmm. Very good. Well, let's go on to our second question. What are the strategies for detecting mild cognitive impairment and mild AD? We're thinking today mostly about mild AD in the early phases of symptomatic disease. So, Ali, what's your approach to doing this?
Well, I think timely detection is really, really critical to improve outcomes. So I think it's really, really important that individuals, if they have a concern, to discuss it with their primary care clinician. Or if there's a concern from a family member that this bubble up to the level of a clinician. And also clinicians can look for warning signs in their patients for this. So the strategies would be really to get start the conversation and make sure that they understand that there is this aging spectrum of cognitive changes, but that people can have damage that's occurring, and you're better off appreciating and detecting it earlier. So involving family members to get a history about change and symptoms from the patient and a family member, I think that's a good strategy. And then doing a kind of a standardized formal review of cognitive systems and function. At what level did they function before? How things have changed now. Mood, anxiety, sleep again, very, very important. Going through individuals' medications. People get on medicines that are not good for them sometimes. Doing that whole sort of pathway. And then ultimately, at least doing a brief cognitive assessment using some standardized instruments. At that point, integrating the information, they may tell you, is something awry? And then trying to understand the nature of it by maybe further cognitive testing in some individuals. If you're unsure, you can refer to a neuropsychologist. And then there's pathways that are multi-tiered for understanding etiology. So I think about, is there a concern? Is something awry? What's the nature of it? At what level? Is it mild impairments? Is it actually at a dementia level? And then doing other tests to think about etiology. And oftentimes in older individuals, etiologies may be multiple, and you can change and affect some of them more than others.
And are there specific tests that you would recommend or think about?
To Ali's point, I would actually routinely order neuropsych testing on patients with mild cognitive impairment. And I've instructed my neuropsychologist to tell me if it's amnestic or non-amnestic. And I really drilled down on that, because if there's a heavy amnestic component, I worry about a prodromal Alzheimer pattern. And if it's non-amnestic, I kind of cast the net more widely. Is it meds? Is it depression? Is it other prodromal?
It could still be Alzheimer's.
It could still be Alzheimer's. So I actually start with neuropsych testing in my practice.
Neuropsych testing. Elaine, what's your approach to the MCI patient?
Well, I always think the most important source of information is a family member who knows the patient well, either the spouse or an adult child. Often, it's more likely that a patient with mild cognitive impairment may have some insight, but once it's progressing into the realm of Alzheimer's dementia, often patients have poor insight. They're really not aware they have a problem. And I've heard it's referred to as denial, but it's really the area of the brain that governs self-awareness is affected early in the course of disease. And patients sometimes just really don't have a clue. So I always think it's important to have a family member involved in taking the history. It's more that you examine the patient and you take the history from a family member.
Yeah, I think that's so critical. And the way I speak with my families about this is I tell them that the patient doesn't remember that they don't remember,
right.
And that makes some sense.
And if you think
to
about
them.
it, in your own as your own self, if you don't remember something, you don't remember that you don't remember.
Exactly, of course. Richard, do you have a standard approach that you use with MCI?
Yeah, so taking a detailed clinical history is worth its weight in gold in a situation like this. The kind of the clinical pearl that I teach my residents and fellows is, when was the very first time that you or someone else in the family noticed anything different whatsoever? And oftentimes that really kind of gets someone to think, oh wait, actually at the birthday party 3 years ago, that's when something changed, or that's when something was different. So really pinning down and getting a detailed clinical history is key. Trying to understand, is this a memory problem or is this something else? Really understanding, could this be a pseudo-dementia, for example, of depression, doing a depression screen, for example. These are some of the really characteristic things. The other really important part is there a family history of Alzheimer's disease? Just because someone has a family member, it doesn't mean they're going to get Alzheimer's disease, but when you have several family members along the chain and they all have presented similarly, that really raises one's suspicion.
That's a really great point. Before we leave this, I want to make the point that doctors have very little time, and we're talking about taking a careful history here. So are there some really key things they should ask? If you had to say, what were the 3 questions that they have to ask to understand this? Are there 3 really high yield questions? Ali, what would you prioritize in terms of what doctors should ask about?
I would really prioritize, if you're going to ask even 2 questions, it would be from the individual and somebody who knows them well. And understanding this change and not attributing change to anything else. Has there been a change or not? And what has been that pace of change? Is it associated with anything else? I think that's really important.